morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audience in different parts of the world. Welcome back to yet another very educative session for you. The speaker for the first session of today's webinar is our special guest from the USA, Professor Michael Ivan. Dr. Ivan is an assistant professor of neurosurgery, chief of services, cranial and neuro-oncology, Jackson South Community Hospital, and co-chair of neurosurgery, Jackson South Community Hospital, director of research at the University of Miami Brain Tumor Initiative. He specializes in the treatment of neurosurgical oncology as well as vascular neurosurgery. He is a noted author with more than 85 publications and 10 book chapters. He has also given more than 70 invited lectures on brain tumors throughout the world. Dr. Ivan is one of the few neurosurgeons in the country with a research lab focused on brain tumors, and he has been awarded with several honors for his outstanding contribution towards neurosurgery. He is recognized as an international leader in neurosurgery and is on the executive board of ACNS and CNS Joint Tumor Section, and is a vice chairman of the YNS committee for the ANS, and is the president-elect of the Florida Neurosurgical Society. We are extremely honored to have him today at our webinars, and today we'll be talking about Glioma surgery, maximizing resection without affecting neurocognition. The speaker for the second session of today is our honored guest from Japan, Professor Ichio Shibahara. Professor Shibahara is a Japanese board-certified neurosurgeon, and he received his MD PhD from Tohoku University School of Medicine, and his research interests are in the pathophysiology of high-grade gliomas, especially invasion and recurrence patterns, which are also the theme of his thesis in PhD. Currently, he devotes his efforts to the neurosurgery in Department of Neurosurgery, Kitasato University, Japan. We are extremely honored to have him today at our webinars, and today we'll be talking about the role of Parieto Occipital Sulcus in glioma surgery. The chair for the first session of today's webinar is our honored guest from Japan, Professor Yoshitaka Narita. Professor Narita is a professor and head of Department of Neurosurgery and Neuro-Oncology at the National Cancer Center Hospital, Tokyo, Japan. He is the co-chair of the Neuro-Oncology Education Committee, WFNS, and director of Japanese Society of Neuro-Oncology and Japan Neurosurgical Society. He also serves as the head of committee of the Brain Tumor Registry of Japan and Committee on Guidelines. He also serves as director of the Japan Society of Intraoperative Imaging and Japan Awake Surgery Association. He specializes in the treatment of gliomas, malignant brain tumors, neuro-oncology, and molecular biology. We are extremely grateful to him for accepting our invitation to chair the session of Professor Michael Ivan. The chair for the second session of today's webinar is our honored guest from India, Professor Atul Goyal. Professor Goyal is a professor and head of Department of Neurosurgery, Leelavati Hospital and Research Center, Mumbai. He is also a consultant neurosurgeon at the Bombay Hospital and Research Center and Tata Memorial Hospital. He is a professor of neurosurgery at the R.N. Cooper Hospital and Medical College. He was a past president of the Neurosurgical Society of India, and he specializes in the treatment of brain tumors, skull base, and CV junction. He is a world-renowned figure who is an invited faculty to several workshops and conferences around the world. We are extremely grateful to him for accepting our invitation to chair the session of Professor Shibahara. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and all the audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today. With that introduction, I would like to hand over this podium to our first chair, Professor Yoshitaka Narita.
Hi, good afternoon and good evening, everyone. Today, I will introduce Dr. Michael Edward Ivan from Jackson South Community Hospital. His talk is Maximizing Resection Without Sacrificing Neurocognition. So let's start the lecture.
Okay, thank you so much for that kind invitation. Honored to talk today, and I really just want to thank the ACNS and everybody here today for taking time out, inviting me and letting me talk about some of the ideas and innovation that we've been developing here at the University of Miami in South Florida. It's early in the morning here. I know maybe late for you guys in the afternoon, but hopefully you guys all already had a good day. So I'm a brain tumor and skull base surgeon here at the University of Miami, and I focus both on both lesions, but today we're being really focused on gliomas. And here's my disclosures and funding. So this idea with brain tumor surgery of tumor resection and neurological function is something that we all are very, very accustomed to, and it's something that we all battle every day in the operating theater. And we often talk about this idea of maximal safe resection. And I put that in quotes because really, what is maximal safe resection? When we talk about it, we talk about removing the tumor based on a preoperative MRI, which is just an approximation or an estimation of where the tumor is. And then we compare that after surgery to what the MRI looks like, which is another approximation of where the tumor is. And so when we talk about maximal, it's an approximated maximal. We really never know how much we removed. And then when we talk about safe, it's also kind of an approximation. We know that these patients, you come in, they walk and they talk, and they leave the hospital, they're walking and talking. But how often do we know whether or not they preserve their higher order neurocognitive function? If a patient of yours is a vice president of a major company, what is the percentage chance that he's going to be able to go back to that level of functionality a week, a month, 6 months after surgery? What can you tell that patient? And so I would obviously say that this is also approximation, that we tell these patients what we think is going to happen, but we don't really know. So what is this idea based off of? Well, obviously there's a tremendous amount of literature. Probably one of the more popular papers is by Dr. Sinai out of UCSF, which is where I trained, looking at extended resection for gliomas. And we know that extended resection, the greater amount of extended resection, the better these patients do. These are been talked about endlessly. And even when you do first, second, third, and fourth resections, this holds true, a bit, small improvements. But I would argue that this is, again, based on approximations, right? These numbers, this data is all based on an MRI that's approximated of where the tumor is and where the tumor was before and after surgery. We've done this ourselves. We've looked at supramaximal resection and operating beyond the contrast enhancement, removing the flare signal, and how this also does improve patient survivability when you preserve function. But again, it's an approximation. So if we look at the last 30 years of brain tumor surgery for gliomas, what have we really developed in order to improve tumor resection and safer surgery? Well, we've done the MRI with gadolinium. Many of us use advanced imaging like MR spectroscopy or PET and intraoperative fluorescence, which just in the United States has been FDA approved for the last couple of years. But overall, in the last 10, 15 years, it's been pretty minimal changes. Same thing goes with safer surgery. What have we really done to actually kind of make sure that our patients cognitively are preserved for quality of life over the last 10 or 15 or 20 years? Well, obviously navigation has been huge. Development of tractography now understands where the tracks are in functional MRI. Neuromonitoring and intraoperative mapping have all allowed us to make advances forward, but still really can't tell me when I'm talking to that executive or that engineer or that astronaut, what is going to be the loss of their IQ, of their eloquence long term. And then it's metabolized. So let's just talk first about tumor resection. We have our MRIs, which estimates, but what is the gold standard? The gold standard is really our frozen pathology. Frozen pathology during surgery tells us when we've reached the tumor margin. And what has really kind of changed since 1905, which is really when a frozen sample, the pathology protocol for frozen samplings was developed. And these are kind of some of the current events that are happening at that time. Not much has changed. But in the last 5 years, I'd say there's a tremendous amount of development in novel intraoperative techniques to kind of understand tumor margins in new ways. And I think that's really exciting. One of the ways that we're using here at University of Miami is with Raman spectroscopy, which is a way to actually use a Raman scattering microscope to actually look at tissues on a slide and quickly kind of come up with a digital picture that represents what a frozen would look like. And this development was kind of made in University of Michigan with the Invenio team back in 2013-15, and then kind of developed through there. And so what it does is basically, instead of having these 17 steps of your frozen sample, which normally takes in our institution about 30 to 40 minutes to get that result called to you, it kind of minimizes it to just one step, digitizes the image, and then sends it directly to the operating room. And the images are quite good. I mean, if you look at a meningioma, here's what a frozen would look like. Here's what Raman looks like. Here's a pituitary. You can see the cytoarchitecture is preserved. Again, glioblastoma, you could see kind of this higher intensity of high density of tumors and necrosis. And even as you kind of march through a tumor going from high grade to low grade to normal brain, you can kind of easily see that there is this kind of change in the cell density and the cells that you're seeing, indicating that you're kind of getting towards the end of the tumor. So when you're doing glioma surgery like this left frontal GBM, you can kind of start with the center with the necrosis, you march out to the ring enhancement, and then you're deciding whether or not you need to take the flare or not. Now you could actually have quantitative data of understanding, is this actual tumor or is this just cytotoxic edema? And you would say, okay, well, what about other tumors? Well, skull-based lesions, typically the margins are much more clear, but I would argue that in some aggressive tumors, like this is a grade 2 meningioma that had extensive involvement in bone, the muscle, and the orbit, it was helpful. As we marched through this tumor, we got through here, you can see meningioma, we can even identify it's atypical. We see that the tumor is invading muscle, it's invading the bone. We got anteriorly to the lacrimal gland, and there was the border was not great, and we were wondering, do we need to take the lacrimal gland in this patient, which obviously would have a kind of a significant change in his outcome. And we took samples on the Raman, and we saw that it was clear, and we ended up leaving that. So we've been using this technology now for the last 2.5 years. We've published on it. This is our initial kind of validation trial where we looked at about 82 patients, and we compared kind of the Raman to frozen. We showed that the lesion detection by our pathologist looking at it was actually 95% accurate with understanding lesion and non-lesion, and equally as accurate with making a diagnosis at that time point, which was within a few minutes. Initially, when we set this up, we were cutting down our frozen time from about 40 minutes to 8 minutes. But since then, we've kind of implemented Wi-Fi, and it's all kind of much better connected. And I would argue that our times now are less than 2 minutes to get each sample kind of back to us in the operating room. So when I operate now, when we're in the operating theater, we have the scope, we're taking our specimens, and as the specimens kind of get registered by the machine, they directly go into packs and they get uploaded on the screen above us. So all I have to do is lift up my head and kind of look at what these pathology margins are looking like to give me a direct feedback as to whether or not I continue operating or not. So that's great, but how can we, I'm not a pathologist, and our pathologists are great, but they're very busy. So how can we kind of assist with that to the next level? So we worked with the team at University of Michigan, NYU, and they were developing this kind of AI network to look and see if we could detect automatically margins and diagnosis. And so they used kind of a library of about 3 million images to train a CNN. And then based on that, we kind of chose the top 10 tumor diagnosis. We then used a validation cohort of 368 patients from multiple institutions and fed that in there. We're able to actually predict within 2.5 minutes the diagnosis of the tumor at the time of surgery, 95% of the time, which was almost better than the frozen sample. And since this was published 2 years ago with our team in Nature, we have since kind of worked with the Invenio team to actually develop an algorithm to understand lesionality during your biopsies. So now on the overhead screen when I operate, not only do I get a picture of the pathology, but I get an AI kind of evaluation of what that slide is, telling me tumor, no tumor, and what is the percentage of tumor, no tumor. So in this case, so red means tumor, down here, green means no tumor, and blue means undetermined. And so we're working forward to validating this idea of getting direct feedbacks and margins using AI. Can that really provide a surgeon quantitative data to kind of make that decision when to stop and when to keep going during surgery? And we've developed our own kind of startup software company called TumorNet that actually will process this data and now kind of help guide tumor treatment both intraoperatively, postoperatively, which will look like this. So what about on the safer surgery side? Now we understand, hopefully in the future, of when to take that last piece of tumor and when not to, but how do we know that we're not injuring the patient? We know very well, we've done very well as neurosurgeons protecting motor and speech, but again, what about all these other neurocognitions? And that kind of leads us to this idea of connectomics, which I know you guys have heard very frequently. The company Omniscient, Dr. Shagru, has talked to you on this webinar and is really giving you a great detailed kind of insight into that. But just a quick overview, connectomics is the science of analyzing all the connections in the brain and understanding their networks. And so what we, all areas of neurosurgery and neurology, we deal with these problems that injure the brain, and we're trying to predict how these outcomes of these patients would be. And all we have is our history, our exam, and our images. And so we basically have like 10 data points to predict how this 25 million dimensional problem of connections will change and alter somebody's cognition in the future. And it's just not a big enough data set. We don't have enough data in order to make those decisions. So what we need to know is really everything about how these patients' brains work, their connection, their network, how well the network is functioning, in order to really understand what their quality of life is and how to preserve that quality of life going forward. So what we get now is an MRI. Many of us also get functional and tractography, but what we actually need is currently a better wiring diagram of the brain, how it works, and how these connections are kind of optimized in efficiency. So, one instance is, when I was in medical school, which was not that long ago, we learned about language networks, and we learned about Broca's and Wernicke's and the arcuate fasciculus. But we know now that the language network is actually much, much more complicated. And these are things that we need to know when we're doing these awake speech mapping cases to understand what areas are we stimulating and what is causing initiation, what is causing paraphases, what's causing, receptive aphasia and whatnot. And so, this model was recently published in neurosurgery by the UCSF group, looking at exactly what are all these components that we need to be aware of in the speech language network. So when we discuss quality of life, it's much more than motor, visual, and language. It's all of these other things. How do you test somebody's metacognition in the operating room? How do you test theory of mind and memory, empathy, etc.? These are very challenging. We need something else. So here's a case. This is a left temporal glioblastoma case, and you would immediately say, okay, as a neurosurgeon, needs surgery. We're worried about speech. We're worried about motor. We're going to do this case awake to preserve function. When I would argue that actually all of these networks of the brain are involved in this tumor and have significant importance to preservation. And so how do we ensure that? We'll do the case awake to preserve language and motor, but how do we preserve, the central executive network and salience? Now, I'm not going to go through what all these networks do because that's an entire day of lectures. Many of them we're very accustomed to, visual, sensorimotor. Some of them are a little bit more obscure, like the default mode network, dorsal attention network. But just to give you an example of what some of these are, and how they kind of interact together is, when we're listening to this talk here today, you're paying attention and you are, your salience network is kind of making the rest of the world kind of die down, and you're focusing on trying to remember, understand, interpret kind of the slides. And that's your dorsal attention network kind of talking to your central executive network to kind of do that. But inevitably, you've had a long day, you've already done 3 cases, and you're thinking about how those patients are doing. You're thinking about how am I going to get home? What's going to be for dinner? What should I pick up on the way home? And this is like kind of your internal monologue that goes down. And when your internal monologue kicks in, you kind of don't listen to anything else. You don't hear the talk outside. You don't really pay attention to me, but you are still goal-oriented. You're trying to think about what you need to get done today. And that's your salience network talking about your kind of pointing towards your default mode network, which is also communicating with the central executive network. Just an example. I mean, how do you map that in the OR? Well, obviously, you need something else. So we turn to kind of the connectome and the brain atlas. It was very well described in 2016 in the Global Connectome Project, but they looked at normal brains. So when you take this and you then apply it to a tumor with a significant edema, brain shift, it becomes a little bit more complicated and there's error that's introduced. So we've been working with a company called Omniscient, which was kind of co-founded by one of my co-residents at UCSF, Mike Shagru, and he has worked with this company to develop an AI network to basically input functional MRI, tractography, and then apply AI algorithms to establish where these connections are and how to interpret them very easily. And so when we're looking at kind of cases like this, where you have a large basal ganglia glioma and you're having significant movement, you need a software that could kind of predict where is the caudate, where's the putamen. You can see how it significantly shifts, and it will find that for you and actually know where it is, taking into account all the shift. Here, when you have a tumor with significant, near these tracts with edema, you want to make sure that the edema is not kind of dulling the idea that you could see these tractographies and pulling it out instead. And so you need to have edema correction. So where are we going with this technology? Well, I think it's no question that you can use this technology similar to how you're doing connectomics. So when you have something like here with a non-dominant parietal met, and you're deciding, okay, which going to be my optimal track, we very well see in the last couple of years the ability of tractography to kind of look at what is the tract with the least amount of damage. What we don't really see is, okay, well, I know the tracks, but show me the networks, show me kind of the key networks that are going to be a problem here. Where is the visual cortex? Well, we obviously will plan around that. So we plan our trajectory to avoid the visual cortex and the tracks that are going to the visual network. And so we initially planned kind of where that trajectory would be, but then we add something else in, like where is the non-dominant language network on the right side, and we see, well, our track is actually in this area, and we need to actually move that up. So not only just knowing that there's a track there, but we're understanding what network this is associated with, what is the risk of that network, and how to move this to kind of minimize our area. So, we did this case with a small Vicor port and able to, remove the tumor easily. Patient went home the next day. We avoided any deficits. But this is something you could do with tractography. But what are we looking at kind of now with understanding networks and things that we don't really know very well? This is a patient of mine, a left frontal anaplastic astrocytoma, resected a couple of years ago, underwent treatment, and now having this non-enhancing flare, kind of increasing tumor, kind of moving more posterior on each scan to a point where we finally decided this is the time for surgery. Obviously, the biggest concern for this patient is an SMA syndrome, but can you predict that preoperatively? Is this patient going to have it or not? We did this case awake. We mapped him. There was no kind of stimuli that caused arrests of movement or of speech. We put the patient back to sleep at the end of the surgery, woke him up in the ICU like a half hour later. He was aphasic. This is his post-op scan. You can see a good resection. But why was he aphasic? Well, he had SMA syndrome, but why didn't we kick that up while we mapped him intraoperatively? And why did that happen postoperatively? And is it going to get better? It's always kind of our fears. And even though we're pretty well described on this area and that it's going to get better, wouldn't it be nice to understand a little bit more about exactly why did this happen? So we looked at the connectomes of this patient, specifically focused on this area called with the initiation axis, which focuses on not only the SMA area, but how it's connected to the DMN and the salience network. And we compared all those networks and looked to see if the tracks are actually involved. And in fact, they were. Postoperatively, the DMN, the salience network, they were still intact. SMA network was also intact. So then why did he have this post-op aphasia? Well, we looked real carefully at all the tractography, and we found that there was small sections of kind of this SMA area that were missing, area 45, 47I, and IFJ. And so we know that the major networks are intact, but we're missing these very small areas of the frontal language network, which, are they important in every patient or are they not important? We need to figure that out. But it gave us some reassurance that the major networks are intact and this patient's likely going to improve. And in fact, by 2 weeks, he was 95% better. And at 2 months, he was completely back to his baseline. So this is what we need to kind of understand better. And until we gather more data, we're not going to be able to predict these very small subtleties in each one of our patients. And it's not just amount of, is the track there or is it not track? Is it the track not there? We have to understand exactly how these connections are made. Are they connected by a hub or not? Which means, are they all going to one center and then branching apart? There's been data that shows that hubness is associated with eloquence. If you look at the top 10 areas of the brain that are hubbed together, 6 of them are normal areas of eloquence. What is the global efficiency in the path link? So if you cut a frontal lobe, the right frontal lobe out, is this patient going to have a drop of their IQ or their eloquence, long-standing? And so a lot of times people can compensate with plasticity and they can develop a new track and they don't have any neurodeficit, but that processing speed is much slower because their efficiency is much less. How much can somebody take before they have a noticeable change? Well, everybody's efficiency is set up differently and everybody can tolerate a different amount. So where we're going towards is what can we do? Can we get to a point where we can do theoretical brain surgery? Can we predict where our cuts are going to be? And then it predict exactly what is the change in this person's neurocognition? What is the change in their IQ? What is their change in their leadership skills? Things that you can't typically map. And then make decisions on how much resection you could do, what is the best approach, and inform the patient better with better consent with what are the risks and benefits of this case. So we're looking at this now. We have a multi-center clinical trial with Omniscient and Staff Strong with these universities here to try to pick this out with gliomas and really understand these really subtle changes in our patients and seeing if we could predict them better in future patients. So far, when we look at our first 100 patients that we've done, we've seen that actually most of the networks that we're affecting are the areas that we don't typically consider to be eloquent networks. And so there's a large amount that we're missing. And in fact, if we look at patients without neurological deficits that we've operated on, 28% of them had a significant difference in their non-eloquent network post-operatively. So they're having some effect. This network is doing something. Whether or not we're tracking it with our post-operative notes and our current kind of ability to look at their neurodeficits is unclear. And this is what we need to capture in order to improve and take neurosurgery really to the next level. So I hope I've convinced you that the future is bright in this area. I think that providing neurosurgeons with quantitative data during surgery about how much tumor is left, how much tumor they've removed, will help them make better decisions on when to stop and when to keep going, combined with a better idea of neuropsychological and neurocognitive outcomes, both understanding what is the best approach and what is a riskier approach, not just talking about speech and movement, but talking about higher order neurocognitive function to really understand how to preserve better quality of life. Inevitably, these brain cancer patients are going to develop better treatments to live longer. And as surgeons, we need to evolve to also be able to provide better quality of life and better neurocognitive outcomes so that now when they start living decades, we can really make sure that they kind of stay at their same level of work and same level of outcome. So obviously this is done with a tremendous team here at the University of Miami, and I want to thank all of my collaborators, many of which are residents and fellows who've dedicated their time, as well as my laboratory that focuses on glioma and invasion and our funding sources. Thanks so much.
Thank you for a nice presentation. So I'm much interested in your brain region connectome project clinical trial. So how many institutes attend this project, and how long did it take to complete the registration?
Yeah, so we're just starting the trial. We're just enrolling now. This is the first month of enrollment. We have 7 sites that are kind of online with a few more that are kind of starting up soon. It's a tremendous amount of data transfer and data transfer agreements that are really the holdup here, right? I mean, it's a matter of transferring whole brain MRIs and their tractography and neuropsychiatric outcomes all to kind of a large data computer that we could really do some AI processing on. And so that's kind of but I think that's really the future, is being able to get large amounts of data to a central hub to analyze it and then come up with these really complicated questions, right? It's not every day that you're operating on somebody with an IQ of 170, and those deficits are going to be much different and much more subtle than somebody who has maybe a lower IQ. Or, that's just one example, but there's a lot of different examples of when you're going to see these very subtleties. You need to gather a lot of data information to kind of pick up every little nuance and subtlety that somebody's going to see with repetition to kind of then come out and say, okay, well, this is the tract and this is the connection, this is the path length, and this is the efficiency that is critical to preserve this specific type of function across the board.
And surgical side is limit for dominant hemisphere or non-dominant hemisphere.
Yeah, we're going to look at both in this trial, both non-dominant and dominant and eloquent and non-eloquent tumors, and basically getting, you know, this really dedicated neuropsych and resting state and functional MRI before post-op, and then several months post-op, and looking at their trend to understand their outcomes.
And do you do awake surgery for dominant hemisphere in your project?
Yes, we do. We do. The type of surgery is not really cleared in the, I mean, you can do whatever you want. I mean, we do actually awake surgery for many non-dominant tumors in the eloquent areas. So that doesn't, yeah, both cases will be okay.
Okay. And how about non-dominant hemisphere? Do you use awake surgery?
We do. Yeah. It's kind of a case-by-case basis. On what kind of function we're really looking to preserve. I find risk and benefits of both non-dominant surgery, you know, preserving function, not preserving function. It depends on how much function and how, you know, how conservative you want to be with the case. I think a sleep surgery actually allows you to be more aggressive. Awake surgery makes you more kind of conservative, but overall, I think, you know, you've better neurological preservation with awake surgery.
Okay, thank you. So do you have any question from audience?
We can invite comments from our honorable panelist, Professor Atul Goel.
Yeah, thank you very much, Michael. You know what, you are correct that there are so many functions of the brain that it is not just speech and motor function. There are so many functions, and the number of functions can be so huge. Like in your Connectome project, I see huge range of functions. So I'm just wondering whether understanding these functions will paralyze the surgeon. If you know that here there is some kind of this function and that function, you may not be able to just, you know, wield your knife. Is that possible, Michael? That is one question. Second thing is, I'm not sure if you have read my work on this subject, where we have said that gliomas are actually very confined tumors. They grow along the fiber tract and they enlarge the tract and displace the adjoining tract. And with the adjoining displacement, they displace the adjoining function also. Essentially, what is the issue is that they are within the tumor mass, there is no function left. This is whatever is function is displaced, and whatever is the function loss is due to pressure and not due to invasion by the tumor. So these, you know, these issues of confined nature of gliomas can have big implication on your Connectome project, where the function as you assess by Connectome project are all displaced. What is your thought on this?
Yeah, those are great questions. Those are great questions. You know, and I would say that, you know, we all do right frontal lobectomies in non-eloquent, you know, right-handed people, and majority of the time those go perfectly fine. Patient wakes up, they go home, there's no issues. Every once in a while, though, you get a patient that you do right frontal glioma on, and you do you know, a lobectomy, and they're just not quite right. They're functionally okay. They're way to go home, but they're just a little bit off. And so I think it's more about trying to find those rare cases where somebody's efficiency and somebody's connections are very fragile, and in those cases, a very targeted lesionectomy is appropriate. But somebody with a very robust pathway and they have lots of different ways to compensate, you could predict that they're going to recover with good plasticity. Those are the patients that you could be more aggressive on, because you know that they're going to recover and develop this ability to kind of, you know, compensate very well. So I don't think it's going to be a matter of avoiding all of the networks and all of the functional areas in the future. I think we're going to, as we learn more about this and we start understanding the nuances, which are, you know, it's even hard to know what we're going to find. You're going to be able to kind of predict now who has that kind of robustness in their kind of brain and who doesn't. And those are the patients where you could now kind of decide, when you have options as a surgeon, how aggressive to be. As far as the invasion goes, I mean, I agree with you. I think a majority of gliomas kind of are confined. Interestingly, my laboratory here at is purely focused on glioma invasion. And actually at the CNS, we're giving a keynote talk on kind of our work and what we found. And we've been tracking patients that don't follow the rule, even because I agree with you, a lot of them do follow this rule. But these patients that their gliomas grow, and we've been taught that majority of the tumor is either at the border or within 2 centimeters of the border. But we do have these tumors that when they recur on the contralateral hemisphere. They recur in another lobe. They recur more than 2 to 3 centimeters from the initial site. So those tumors are obviously tracking along those white tracks. And why are some gliomas tracking so kind of spread out, and why are they not? And we've identified kind of a receptor on gliomas that we could actually modify. And in mice, we could kind of make a tumor completely confined, and then we could modify the receptor and actually change the glioma conformation to actually be completely dispersed and go off to the other side of the mouse brain. And so that's what we're going to be talking about. And there is a percentage of gliomas that we've shown that don't have this receptor, that they're unable to stay confined, and they kind of leave the nest and they go out. And whether or not it's important to get all of those last cells during surgery or not in those patients, I think is still yet to be determined. But unless we kind of understand that and then get the quantitative data during surgery of, okay, you know what, we did a good resection, but the cell density in this patient and the backside of this tumor was still 10 per 100, and that's what recurred, or that's not what recurred. We need to start kind of understanding how those recurrences happen, and to kind of, like you said, understand, is this a confined tumor? Should we restrict our surgery to just that confinement? Or is there some cases where this is a tumor that's going well far into the frontal lobe, and this is a patient who could tolerate a frontal lobectomy, and that's the patient you should do the supramaximal resection on.
Thank you. Thank you, Michael.
Sure. Yeah.
Thank you very much. Yes, Professor Narita.
So regarding to Raman microscope histology, is it very popular in the United States?
Yeah, so that's a great question. I think there's about 10 universities now that are using it pretty normally. There's a lot of new devices that are kind of coming up now with this ability to kind of detect tumors in the operating room for cancer surgery, not just for brain surgery, but for all kinds of cancer surgery. And so I think you're going to see the biggest change in the next 10 years is kind of, which one of these technologies will win out. There's ones that you could actually probes in the operating room where you could actually kind of detect tumors as you're operating in the cavity. This one, you have to take a biopsy and get a picture. We like it because there's some ability in the future to kind of detect mutational status of the tumor and genomic status of the tumor as we learn more about it. But yeah, I think it's unclear kind of if all these technologies will be kind of working together, or if one technology would be better than the other one. Right now, this one has the best, most precise and clearest data, and so that's what we're working with. But it's going to be a space that we're all going to have to kind of be accustomed to of how to use these intraoperative detection methods while we're operating.
Yeah, it seems very useful to detect the border of tumor. Yeah. Okay, other questions?
Yes, I would like to ask Professor Michael even that though the analysis of tumors through Raman fingerprint is very, very interesting and novel, but it is still not approved by FDA. Is it true?
Yeah, well, so the Raman microscopy, interesting enough, is basically been approved as in the United States 510(k) approval as a microscope. So basically, it's a novel way to take pictures of your pathology and to then have the pictures. The part that becomes interesting is in all of these devices is then how do you apply AI, automatic learning, and to give you the quantitative yes or no answer that you want as a surgeon while you're operating. And so, there's been a few devices in the pathology realm in the United States that have gone through the FDA in the last year and a half for breast and for prostate, looking at pathology. And we're hoping that that's going to set the bar of exactly how to get these new AI and neural networks approved through the FDA, because this is a network that's constantly changing, right? The more data you feed it, the better it's going to get. And so there's challenges with FDA and all, in the US and also in the world of how you can approve an AI that's constantly evolving, constantly improving. Do you need to get, yearly validation checks? It's a whole discussion. It's really interesting to see how that field is going to kind of move forward. And the same thing goes with radiology, right? I mean, there's a tremendous amount of AI now that's getting approved for detecting subarachnoid hemorrhage, detecting stroke, those algorithms are just going to improve as time goes by.
Definitely, we are all looking forward to that. Yes, Professor Takashi Kon from Tokyo has joined us. Any questions from you?
Yeah. Thank you, Dr. Michael, for wonderful lectures and very astonishing and SRH, especially SRH stimulated Raman histology. The accuracy will be more than 90%. So to get more accuracy, what kind of factors are needed to complete diagnosis now in your institute? Your opinion, please.
That's great. Interestingly, in the Nature paper, when we looked at the accuracy and we found that it was 95% accurate, and then we found that the pathologist was also about 94.5% accurate. The samples that they were getting wrong were opposite. So in each cohort, the pathologist got, 5 wrong, and the AI got 5 wrong, but they weren't the same 5. So it kind of, in the future, it kind of goes to believe that, the human pathologist and the AI will eventually kind of be able to work together to kind of improve that accuracy. The other thing you have to remember is that we don't give the AI any hints. This is not like, as a pathologist, you get to look at the scan, you get to know the age of the patient, you get to kind of understand, is it intraaxial, extraaxial, you get some clues to kind of help focus your differential. But the AI gets nothing. We didn't feed it anything. We just say, here's a picture, tell me what it is. So I think, as you go forward, the ability to add in the patient's, background, their ethnicity, their age, their sex, MRI characteristics, the progression of disease, all of that data will be in the chart and will be extracted. And then you kind of build these larger databases. But you got to start small. You got to start with a simple one before you get to the complex major database.
Thank you very much. We can take the concluding remarks from Professor Narita.
Okay, thank you for nice lecture, Michael. So to preserve cognitive function, we must learn about brain connectome to match. Thank you, nice lecture.
Thank you.
Thank you very much for this wonderful session. We learned a lot about new technologies and Raman spectroscopy as well. Thank you very much. So we'll move on to the second session, and I would like to invite Professor Atul Goel to chair this, and he would say a short introduction and invite Professor Shibahara for his lecture. Professor Goel.
So it is my very distinct pleasure to invite Professor Shibahara to give his lecture. And I know he's going to talk on parieto occipital fissure and how the tumors have relationship with this fissure. We know the Sylvian fissure, we know about interhemispheric fissure, but not much has been discussed about parieto occipital fissure. And it will be quite intriguing to know what Dr. Shibahara has contributed to this subject. Professor Shibahara, please go ahead with your lecture.
Hi, thank you for the introduction. My name is Ichigo Shibahara, Department of Neurosurgery, Kitazato University School of Medicine, Japan. So today's my talk is about the role of the parietal fissure in glioma surgery. So the organizer asked me to present our latest article published in Neurosurgery, which is this. And okay, so there's no COI. So I'd like to start from the beginning of the study. So in the short period of time, I could experience 3 cases of posterior middle temporal gliomas, which is this image on the slide. And as you see, there's a similarity in radiological images. And if you see why there's radiological similarities, if you see the posterior border, you see there's a clear posterior border, even all of them are the glioblastomas. And if you see the sagittal image, and I noticed something, which is the beginning of the story. So today's outline, I'd like to talk about anatomy around the medial temporal lobe. And then I'd like to talk about how I discovered the role of the parietal fissure in gliomas and how I can apply this to the daily practice. So the anatomy, this is the famous figure from the Dr. Schramm's paper. And this shaded place is the medial temporal lobe. And the widest point of the brainstem, which is the line in orange, can subdivide this medial temporal lobe into anterior and posterior portions. And the Schramm classification type A includes hippocampus, parahippocampus. Type B is a fusiform gyrus. Type C is the combination of A and B. And type D is the type C plus invasion towards the temporal stem insula and the basal ganglia. So this is another article that I found. And I think this is the only anatomical study about the Parieto-Occipital fissure. And in this study, they used the word Parieto-Occipital sulcus. And this blue line is the Parieto-Occipital sulcus, and the green line is the calcarean sulcus. And if you see the anterior or the posterior end of the Parieto-Occipital sulcus, there's some ramification, but if you see the anterior end of the sulcus, there's always the unramified straight sulcus. And the Parieto-Occipital sulcus fissure has no variation. So in this study, they use the Parieto sulcus, but I prefer to use Parieto fissure, and the other studies also use the word Parieto fissure. And as you know, POF, Parieto fissure, divides the parietal lobe and the occipital lobe. But this POF also divides occipital lobe and temporal lobe, which is not known by many people. So this is the temporal occipital line, which is the line between the anterior end of the Parieto-Occipital fissure and the pre-occipital notch POM. And this is another anatomical data. So posterior to the posterior middle temporal lobe, there exists IS, which is the isthmus of the cingulate gyrus and occipital lobe. And the POF subdivides these two components. And anterior and the superior portion of the IS is the SP, which is the splenium of the corpus callosum. And if you further up, there's a parietal lobe. So hypothetically, the glioma at the posterior middle temporal lobe is surrounded by many structures. So they can invade to the splenium, parietal lobe, isthmus, and occipital lobe. This is the hypothesis. So short summary, temporal lobe has anatomical complexity. POF is a key landmark to differentiate temporal, parietal, and occipital lobes. So more than 40% of gliomas located in these three lobes, but the little attention has been paid on POF and gliomas. So this is the background. So next I move to the next slide. So let's get back to the three cases that I experienced at the beginning. So if you see the sagittal image again, then now you can notice that there is a POF on the posterior end of the tumor. And if you see the T2 image, you see the T2 high lesion along the POF, and they only exist on the anterior part of the POF. So I only show the three cases. I look at our database and found furthermore cases. So these are all posterior middle temporal gliomas. And as you can see, they have clear posterior border. And if you see the sagittal image, the POF is always the posterior end of the tumor. And these are other cases. Again, they have a clear posterior border. And if you see the posterior end of the tumor, there are always the POF located there. So I experienced 20 cases. POF is as a posterior border was observed in all cases. Then I checked other anatomical structures surrounding the posterior middle temporal lobe. So this is one case. If this is a parietal fissure. If the case has a parietal lobe invasion, you plot yes on the parietal lobe. If they have the isthmus invasion, you plot yes on the isthmus. The same thing, splenium. If there's a splenium invasion, you plot yes. And if you have occipital lobe invasion, you plot yes. And this is the demography of the posterior middle temporal gliomas. So this is the plotted result. And if you see the result more in detail, so isthmus invasion was observed in 19 cases, whereas only occipital lobe invasion was observed in 4 cases. There was a statistical difference by McNamara test. So, and then I checked the 4 cases of occipital invasion. And these are the 4 cases. As you see, there's a posterior POF at the posterior end of the tumor. And all the occipital lobe invasion has to detour from the outside towards the occipital lobe. So in other words, medial part of the occipital lobe is always free from the tumor. So there's a question. Why do glioma cells invade toward the isthmus, not towards the occipital lobe? To answer this question, I tried to use the DTI data from our cases. And these blue lines is a POF, Parieto fissure. And I placed ROI, region of interest, on the posterior middle temporal lobe. Then you see 2 bundles of fibers, which is subdivided by the Parieto fissure. Then to further analyze the data, we used the DSI Studio. This DSI Studio had a database about 1,065 subjects of DTI data. And again, if I use this data and place ROI on the medial temporal lobe, you saw 2 bundles of fibers. And what are these fibers? If you rotate this image, it will be like this. So these are the 2 fibers that I showed just before. And there's the blue line is POF. And the POF is a sulcus. So of course they have a width. So due to the width of the Parieto fissure, the occipital lobe invasion is not possible. Due to the width, even glioma cells has to detour the width of the POF to reach the occipital lobe. But in fact, even glioma cells, they tended to invade toward the easier part, which is the isthmus. So they tended to go to the isthmus, and some go to the occipital lobe, but they had to detour the POF. So this is the final schema of our study. Due to the POF, the white matters has to detour the bottom of the POF, and the glioma cells at the posterior temporal lobe has to detour this the bottom of the POF. So this is another case. As I showed you before, you will think that this case is the posterior temporal lobe gliomas. But if you see the sagittal image, you notice that this is the tumor locates at the cuneus. Therefore, the POF locates anterior to the tumor. And this tumor tried to invade anteriorly, but due to the POF, they has to detour the bottom of the POF, as I showed you in the medial temporal lobe, posterior medial temporal lobe gliomas. So this is exactly the case of the vice versa of the posterior medial temporal lobe gliomas. So the POF affects not only the posterior medial temporal lobe gliomas, but all gliomas surrounding the structure. So how this finding can be applied to daily practice. So I'd like to show one case about the surgery. So as my data showed, POF is always the posterior border of the medial posterior temporal gliomas. And this is the POF. And if you do the surgery for this case, you have to think about the cerebral tentorium, which is the inferior border of the tumor. And there's also corpus callosum invasion. And this is a position of the case. And I used a corticotomy to assess the tumor. And this is surgical video. After the corticotomy, I reached the trigon and identified the void plexus. And the tumor is grayish and very soft. So I obtained some tissue for the gene analysis and the histological analysis. And this part you saw an artery in the sulcus. This is a POF and the parietal occipital artery running within the POF. And this is the medial border of the tumor, which is the subarachnoid membrane facing the brainstem. And this is the cerebral tentorium. This is the inferior border of the tumor, and this is the safest place to remove. So you just suck up using the sonopet, removing the tumor from the above the central cerebral tentorium. After exposing the cerebral tentorium, the artery in the middle is the parietal artery. And the cerebral tentorium was exposed. And this is the medial end. And you can see the ICV and the Galen complex through the subarachnoid membrane. And this case had a splenium invasion. So this part is removing the tumor at the splenium. And this is the final view. On the bottom, you can see the cerebral tentorium and the medial portion of the subarachnoid membrane was shown. And this is the post-operative MRI. The gadolinium-enhanced lesion was removed, and as I showed you, the cerebral tentorium was exposed, and I also exposed the internal cerebral vein. And the parietal fissure is, of course, the posterior end of the tumor. So the conclusion is direction of the glioma invasion is highly influenced by sulci and the white matter fibers. Parietal occipital fissure is a key landmark of posterior medial temporal gliomas to understand the anatomical architecture and determine the surgical strategies. Thank you.
Thank you, Dr. Shibahara, for that wonderful new point. You see, what you are saying is that the parieto-occipital sulcus or fissure forms a limiting membrane for the tumors. And that is a very novel kind of thought, and I congratulate you for thinking about it. You see, there is an interhemispheric fissure and there is a corpus callosum. If there was a corpus callosum-like structure in the parieto-occipital sulcus, then the tumor would have gone from one side to the other side. But unfortunately, or fortunately, there is no connection on the surface of the tumor. However, the short arcuate fibers in the depth of the sulcus is where the tumors go from one side to the other side. And, you know, this is very much in, I agree with this, that according to our own understanding, that the tumors will go along the fiber tracts and they will be involving the fiber tracts and they will be displacing the fiber tracts. This, your understanding is very much in, you know, in sync with what we think about it. Now, one thing which I didn't appreciate, and I want your comment on that, this parieto-occipital sulcus, you have said, is a very distinct border, but you have not used it for surgery. You have gone transcortical approach. Whether you could have used this parieto-occipital sulcus and used interhemispheric approach, which is much more popular and much more, you know, has been recommended by Yasser Gill, much more safer as regards the white fibers on the surface. You know, you can avoid the calcarine sulcus and the visual pathways and go along, use the parieto-occipital sulcus to enter inside the brain along the medial interhemispheric approach. Why you had to use transcortical and use such a big cortical incision? What is your comment, Dr. Shibahara?
Oh, thank you for the great comment. I completely agree with what you said. I just show the case of corticotomy cases, but we recently performing so-called like a parieto-occipital fissure approach, which is approaching in the interhemisphere and dissecting the parieto-occipital fissure like Sylvian fissure. And as I showed you, the parieto-occipital fissure will be always the posterior border. So if you dissect the fissure, you can automatically get the posterior border of the tumor. So I usually use this for the dominant hemisphere, but the specific case that I showed you, this case had a hemianopsia from the beginning, so they have a vision defect. So we chose the corticotomy approach.
Another question which will obviously be very commonly, when we do interhemispheric approach, use the Parieto occipital sulcus, use the calcarine sulcus, use the isthmus of the corpus callosum, splenium. What will be your, when you are going to enter the brain, what are your parameters to prevent the visual pathways? What precautions you will take so that you don't damage in the interhemispheric exposure of the tumor?
That's a good question. So my understanding is anterior to the POF is a parietal lobe, basically. So it's not the occipital lobe. So if you treat gently the occipital lobe, I can avoid the visual deficit. That's my understanding.
Anyway, what Dr. Shibahara you have introduced is a very fantastic new thought in the subject of gliomas as to how the fissures and sulci limit the extension of the tumor and how the tumors, they don't cross the sulci, they don't cross the fissures. They remain on one side of the fissure. They extend along in the substance of the brain and not along the fissure. And this limiting membranes, this limiting sulci can be a wonderful landmark during your surgery. And then you can, do a dissection, keeping this sulci, protect this sulci and work inside the confines of the tumor. I think very good thought, and I congratulate you on the work. And because I completely agree with this concept of confinement of the tumor and restriction of growth of tumor along the sulci. It never happens. The tumor will never go along the surface from one side of the sulcus to the other side. If at all, it will go in the depth of the sulcus. So thank you very much, Dr. Shibahara. My best wishes to you. I hope you can work this project on other sulci like Sylvian fissure, like other deep brain sulci, like even calcarine sulcus. You can work on how the tumors respect the calcarine sulcus, and tumor remain on one side of the calcarine sulcus and on the other side of the calcarine sulcus. You can work on the medial temporal gliomas like parahippocampal gyrus and how the tumors remain confined to the gyrus and do not go beyond the gyrus. I think this is a very good way of analyzing and studying gliomas. And my best wishes to you, Professor Shibahara.
Thank you very much.
Thank you very much for this wonderful lecture, Professor Shibahara. As soon as I read it, I thought this was one of the best newer thinking in gliomas. Well, we have Dr. Abida Shah with us. Any comments, Dr. Abida?
Yes, Raja. Thank you, Dr. Shibahara. That was a very good lecture. And as you have heard from Professor Goel, we have a philosophy where the tumors grow around the white fibers. So what you have shown basically is the tumor that is present in the posterior medial temporal lobe is growing actually along the cingulum. So it is following the fiber tracks of the cingulum. So when it goes from in anterior to the parieto-occipital fissure, it is actually tracking along the cingulum and curving along the corpus callosum superiorly. When it goes towards the parietal lobe, it is tracking towards its parietal communication with the precuneus. And the occipital connection of the cingulum, there are very few fibers that go. That is why the invasion is not seen towards the occipital end. So this is our understanding. And as said by Professor Goel, we prefer a medial approach because coming laterally will damage the optic radiations. And even coming from medially, if you do not violate the atrium, if you do not violate the middle wall of the atrium and the roof, you will preserve the optic radiations. So that is my comment. But that was a great lecture. Thank you.
Thank you for the great understanding. Yeah, what you said is exactly what I want to say. Thank you.
Any comments from Professor Narita? Professor Narita, are you here?
Yeah, I often discuss with Dr. Shibahara about his presentation. Yeah, it's very nice presentation. Thank you.
you.
Well, thank you very much. So we can wind up this session now and we can take the concluding words from Professor Goel.
Now, in general, glioma surgery has evolved. The use of various monitors, the various technological innovations, radiological innovations, understanding, and the recent thing about connectomes and all those things are the way we have evolved in understanding brain in general and gliomas in particular. I think glioma surgery is an absolute fantastic surgery. And as you know, as per our recent understanding, they are labeled as diffuse, they're infiltrative and all those things, but they are, the gliomas are confined, and this confined nature of gliomas has to be exploited. They remain very much confined, they displace the adjoining structures, and you can remove this tumor almost like en masse. So this concept that we have developed can reduce our dependence on various other things of technology. Even awake craniotomy can be avoided if we get to the glioma and start dissecting along the surface of the glioma and have the ability to resect it completely en masse. Of course, gliomas cannot be resected completely. They are cancerous tumor. The cells are here and there and everywhere. But whatever we see, we have to resect. And if we resect maximally, the outcome is better. You can avoid radiation treatment in low-grade gliomas. So all these issues have to be studied, and the work is still in progress. And I'm sure with these young neurosurgeons in Japan, in various other countries, the baton will go further ahead. So thank you very much, Dr. Raja, for inviting me to this show, and Professor Yoko Kato's contribution to our understanding of the entire gamut of neurosurgery will continue. Thank you very much.
Well, thank you very much. That brings to the end of this session as well, and I'll close it officially. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to thank both the speakers of today, Professor Michael Evan and Professor Ichio Shibahara, and the chairs, Professor Yoshitaka Narita and Professor Atul Goel, for their time and support for the ACNS webinars. A big thank you to all the elite panelists who joined us today. And I would like to sincerely thank Professor Shubin for broadcasting this on the WeChat channel. And as of now, we have around 550 people who have joined us live, combined on all three platforms. So until we meet again next month, it is bye-bye from all of us. Thank you very much for joining.